Good morning, everyone. Especially thanks to the audience who have joined on a Sunday morning at 10. So, at Insightful, we are trying so that both our knowledge bases, clinical skill bases, are updated constantly. And for that, we are starting off with a journal article discussion series today where we have the authors with us, basically. Uh, Indranil sir will be discussing the article, and hopefully the other author, Saheli, may also join the discussion. So, good morning, everybody, and welcome to the journal article discussion series. I will quickly introduce Dr. Indranil. He doesn't need an introduction. He has been a teacher to many of us. So, yes, I'll just wait for the screen to get up. Yes. So, Dr. Indranil Chatterjee, he holds a PhD in audiology and speech language pathology from MUHS Nashik. He also has a PhD in psychotherapy and counseling, as well as an MBA in HR. He is presently the lecturer in speech and hearing and is also the in charge of the Department of Speech, Language and Hearing Sciences, Academics, Clinical and Research Coordinator, that is his additional charge at AYJNISHD Regional Center in Kolkata. He is the former General Secretary of ISHA between 2017 to 2020. He is the life member of several professional associations, and there he has a total professional or teaching experience of 21 years. He has guided more than 200 master's dissertation in audiology, speech language pathology, special education, and dentistry. He has more than 120 peer-reviewed indexed journal articles. He has 120 publications in peer-reviewed indexed journals. He has written several chapters in the books of audiology, speech language pathology, special education, and otorhinolaryngology. He has achieved Manohar Memorial Awards for scientific presentations from Isha and ISHACon 2020 at Chandigarh along with students. His areas of interest and research include auditory electrophysiology, tinnitus, vestibular science, voice, fluency, dysphagia, and cognitive sciences. He's a founder and convener of IASLP webinars, SIG initiative of the Schwab since 2020. So welcome, sir, and thank you for accepting the invitation to talk about an article that was published in December. Please go ahead, sir.
Thank you, Devasmita Madam, for these warm introductions. Good morning to everyone. Thank you for the opportunity for presentations. Actually, this background of this presentation, it is basically a clinical case presentations of my institute. It has been done by Saheli. And then there are some lot of team have worked, like Rumela, Hasan, everyone. And we have thought that we should present it in, we should publish it. So based on that, we have worked on that, and the patient has improved a lot with reference to that apraxia and drooling and cialorrhea, etc., etc. Though this area is not the strong area, or it is my interested area, actually I'm not working in child language in that way, but in this particular case, I have learned several things which I have to share my experiences when I have during my course of my learning in this particular area. Just I share my slide.
Yes, sir. Yes, sir. Please do.
Is it visible to all of us?
No, sir. It is just a blue color screen. We cannot see any text on it.
Okay, just a minute. Maybe. Now, please check.
Yes, sir. Now, sir, please go to the slide show mode. Now we can see the PPT, the PowerPoint application.
Slides, so I have done. Just check whether it is there.
No, sir. It is still in the PowerPoint application. It is not in slideshow. in the slide, huh, sir, not the slide show. Like I can see your rest of the slides on the left-hand side, basically.
Okay, okay. Just a minute. No. Is it there?
Yes, sir. It's again, ha, sir. Yes.
So, good morning, all of you. Just I am sharing my learning experiences on this particular case, and it has been published in International Journal of Otolaryngology and Head and Neck Surgery recently. But the credits goes to my students who have done the work. I am just the facilitator of this particular study. As Devushmita has told me to present, so I would have been thought that I should present this particular part, because nowadays this part has is actually is under the much more query and much more impetus, because it is getting impetus. Like uh, there are a lot of instrumental companies are coming up for the management of oral apraxias, as you all know, that number one, talk tools, number two, speech gear, number three, set speech, lot of instrumentations. And previously, when I was student at Ali Jawarjang, Mumbai and Kolkata, during my bachelor's and master's, that time hardly there were some equipments which we pass on for those type of management. Usually we use tongue depressor, we use some the regular brushes, or sometimes the vibrotactile brushes also, but not that type of very strongly designed scientific equipments like talk tools, speech gear. Speech gear is make in India product, so it is widely available. Even set speech and others, so a lot of new instrumentation I am getting it. So all are mostly make in India product, and those are cost friendly, and they are using it for management of CLORIA, means drooling and other apraxia issues. So my topic of presentation is today's my topic of presentation is oral motor learning principles in a child with severe communication disability. So patient is having cerebral palsy, seizure disorder, profound, severe to profound mental retardation, still walking is the difficulties, and the late intervened child having lot of communication issues. Even the sensorium issues are very, very prominent. So today my presentations talks about few keywords like oral motor learning. Like as we all know that SCIMIT has given a proposal of oromotor learning, that is one technique is called schema theory, applications of motor learning principles, and based on the sports medicine aspects. And SCIMIT has given a lot of methods how to do practice, how to get feedback. There are a lot of methods of the motor learning principles, and oral motor learning principles is the subset of the motor learning principles, because motor learning principles used mostly in the all aspects of physiotherapy, occupational therapy, everywhere, even in speech therapy, while where I will talk about these particular aspects of either non-verbal oral apraxia or oral apraxia. In that way, there are a lot of apraxias also. Again, it is another chapter of interest. Sensory integration is a part where a lot of sensory processing is the aspects. Even sensory modulation is another aspects to be we as an SLP we should think about the sensory modulation aspects. Then cerebral palsy is the area which in this particular case is having cerebral palsy. Drooling is the issues, and as well as drooling, when we are managing drooling and other aspects, communication disorders also taken into account, and it has been improved but it is slightly improved. So this is the aspects to present in this particular aspects. So in this particular case presentation, the abstract is the use of oral motor learning principles in a child with severe communication disability. This is basically a case study So I cannot conclude any evidences because it is not a study of interest, because there is no strong methodology has been used, because it is basically a case study. And it can provide only the glimpses of a child with 7 years, 7 months, male child of cerebral palsy with an intellectual disability and seizure disorder. And our aim is to improve oral motor skills and communication skills. So as we all know, cerebral palsy is a group of disorders that affect a person's ability to move and maintain balance and posture. Cerebral palsy is the most common motor disability in childhood. Cerebral means having to do with the brain. So it is a brain disorder, congenital brain disorder. Okay. And basically, the patient is having mostly the hemiplegia and also dystonia and little bit spasticity also, but disability condition is severe, as we have found when we are doing the assessment. And objectives of this particular study is to assess oral motor learning principles in severe communication disability in this particular case, to evaluate impact of oral motor sensory tools kits, that is we have used it here in speech gear, and to track improvement in vegetative functions and speech. So what are the principles of motor learning as we have understood here? That is skill improvement through practice. So practice, practice, and practice. So this is the area. And the three measures we have done, that is acquisition aspects, retention aspects, and transfer aspects. That is the principles of motor learning. As we all know, it is not new. Duffy already mentions all those things in the aspects of pediatric dysarthria aspects. Supports both implicit and explicit learning. That is bottom-up and top-down principles. Even it is mentioned, very vividly mentioned in the book of Murdoch, Bruce Murdoch, and also few book on spasticity and other thing in the physiotherapy. There are two principles which we have to work on. And recently, one master's dissertation is going on in my Kolkata center in MSc Speech Pathology. One person is doing work and developing a new therapeutic management aspects with reference to sensory motor learning principles. So that is under my guidance, it is going on. That is a therapeutic postulates we are proposing in your master's dissertations. If it is been completed, then definitely I will let you know what we are actually doing. Next, what is the difference between bottom-up and top-down processing? So bottom-up processing means it is basically a sensory-driven processing. Sometimes we missed out the informations. Bottom-up means you stimulate, stimulates, and stimulates, so we know that it will be integrated. But it is not like that that very easy. So because it is a time bound, so reaction time is very, very important here. And also there are some oromotor executional aspects are also there, and also top down means cognition driven. So it is basically goal focused task. So we every time there are different sets of cognitive sets we have to set, and we have to track whether all those sensory driven phenomena are changing the cognitive driven phenomena. So that is also another coordinative task we have to do. So both models essentials for effective therapy. So if you only start using sensory integration or sensory driven module, it may not work. So that is the my aspects of thinking after this particular case study, and then it leads to two research. One research that we have to develop some indigenous tool for assessment of apraxia that we have already finished, and another work is just we have started that based on bottom up and top down principles, we have to develop some new therapeutic postulates and therapeutic strategies and probe, so that it can track both the things, because it is not tracking both the things. Whatever I have gone through, so many new aspects of oro optm and other things, they're either tracking sensory driven or they're tracking top down, but not both. Or if they have tackled both also, there are some lacuna based on sensory integration phenomena. That's what I have learned. So oromotor exercises or oromotor executional part is basically with reference to non-speech task for lips, tongue, jaw, and palate. So we have to understand a lot of anatomy and physiology, the origin, insertion, nerve supply, the blood vessels, the blood supply, everything, all those muscles. If you have to understand the non-speech tasks, then you have to understand the improvisations of muscle tone, so hypotonia, hypertonia, etc., or dystonia, and then strength and also coordination. So maybe the gross motor and fine motor coordinations. So it includes either active, passive, and also sensory stimulation aspects. So all are one chapter of interest. So I just provide the keywords here. Next, uh, case profile. So it is a 7-year, 7-month male with spastic cerebral palsy, having seizure disorder, frequent myoclonic seizure with visual impairment. That is another challenge, and also severe intellectual disability. So primary issue was communications via crying only. So there may be some differential cry, but other than that, nothing was there. So there was no babbling around 3 to 8 months, no first word, seizure onset 3 days post birth. So mostly it is an asphyxia baby. So birth asphyxia is predominant, or maybe a meconium inductions, maybe that it is recorded in the thing. So there are a lot of the prenatal issues, and of course there are one issues, or what I have thought, that it is an eclampsia issues are also there. So maybe the mother is having a seizure during the pregnancy, and that is a part. And when we have started testing, so first we have started hearing testing and it found normal. Language assessment, because we don't have any other indigenous Indian developmental schedule of language development except 3D LAT. So of course we have to start with reels, though it is it is not an Indian test, but we have to use, because it is only the module is widely used in the throughout the globe. So receptive language age, it is around 1 month. Expressive language 1 to 2 months. Only some sounds may be there. Sometimes it is meaningful, sometimes it is not meaningful. It is very clumsy, and no history of babbling or first word. 3D LAT has been already implemented, and there is less than 9 to 11 months the cognition was, and comprehension expressions are lagging because it is not completely recognized because of the bizarre nature of the developmental pathway. Communication deal has been already done and found significant delays across all domains. Play assessment has been done to the exploratory level. Play is there, and there is definitely the Renal scale shows level 1 attention, that is the fitting attention pattern. Odomotor assessment has been done based on some checklists and found that there is an oromotor deficit with only the jaw movements, a few movements are there, but otherwise it is not there. So, and also there is a confounding variable like severe drooling. Drooling severity scale is showing constant with wet clothes. So all time drooling is there because there is mouth is not fully closed also. And primitive reflexes is sucking and pharyngeal gag is already present. So we have went through some cranial nerve examination, and trigeminal nerve shows there's a reduced jaw strength, unable to follow muscle testing, sensations too sharp or cold or warm intact in this particular stimulus. Facial nerve testing cannot whistle or follow facial movement commands except smiling. Corneal reflex present, and glossopharyngeal, that is ninth cranial nerve and vagus nerve, testing like gag reflex is there. Cannot produce ha for palate elevations, tastes intact, but normal voice and swallowing, it is also there. And in 11th cranial nerve, unable to follow movement instructions, Hypoglossal nerve like weak tongue strength, no deviations or tremor, inadequate cheek pressure. Key findings, multiple cranial nerves show reduced motor functions, but most sensory functions and reflexes are preserved. Just I'm giving you some examples like this is the child. I have taken the consent from the parents while recording it because for the this purpose we have a consent. Proper consent was there because if we don't record, then how we learn? That's why they have given consent probably, and we have not given anything which is uh, uh, used for other purpose. It is only for the academic and research purpose. So this is the child, and see, when we use the speech gear, I will come in this particular aspects later. So is using he is at least cooperating, but sensorium issues is there. So what the therapy protocol we have followed, that is the 20 sessions initially we have planned for 45-minute sessions. Non-speech or the oromotor exercises we have used mostly, and also we have used oral motor sensory integrations tool like speech gear here. So kits are tactile kit and speech kit. So the tools sensory bite, oro tube pen, and tongue steer. These three we have used. Child and clinician directed methods. Definitely, it is only the method as used by Ria Paul book 2012. It is vibrotactile stimulations we have to provide. So you know that in this particular part, it is a sensory bite. It is oro tube pen for using of multiple. Sensory bite is basically for eliciting of biting reflex initially, but it can be used for tongue resistance and tongue motion exercises. While we putting the tongue into this particular gap, and we can change different directions of the movement through this particular handle. So there are some motional movement or range of motions may be improved. That is in one aspects of sensory biting, but lot of other applications also we are now developing in my therapeutic postulates. What we are developing now, probably in another year we have to publish it, and then we will learn that definitely this area is very well used. Another aspect is oro tube pen, though it is usually the blowing and other things it is used for, but it is also used for resistance of tongue motion things. What we have found in my new techniques which we are developing. Other than that, we use the oro tube pen, that is uni and pointed tip, tongue steer, tongue tip, hickey, and sensory bite. These are instruments we have used for not only the mouth opening things. It is also used for tongue resistance exercises, tongue range and motion exercises, and for developing of different strength of the facial muscles, lip muscles, so that drooling can be checked. So post therapy improvements we have found, like the lip, jaw, tongue control was better. The bolus formation was improved. Drooling was significantly reduced from severe to mild in the drooling scale, and more consistent spontaneous swallowing. So, but cranial nerve functions, though these functional aspects have been improved, but the cranial nerve function in a general holistic view, we are not getting the strong improvement, but though there is a slight improvement we have observed. Post-therapy improvements in case of language, we have got that voice and music that the child is recognizing very well and consistently, not in the reflexive level, but also maybe in the cognitive level, but still there are some lacuna in assessment of that, because everything is like functional assessment. There is no appropriate scaling or objectivity for assessing all those very severely disordered child. Vocalization of vowels like a, e, o has been started functioning. Slight improvement in receptive and expressive scores in reels and comdil have been found. So overall outcome, improvement in vegetative functions, reductions of drooling, and better communication readiness with early vocal expression. So just few uh, assessment, the the management aspects. You see that the mouth opening has been improved, and when we have started some resistance through jerk and through the motional resistance exercises, even when you use the V pen with the proper tools, there are a lot of changes in this particular movement. You see, probably uh, there are some motional activity and apraxic changes have been found. So we have taken it from different oromotor exercises, principles, and books we have. So based on that, we have started thinking that how those tools have been used with the help of this particular therapeutic postulates already has been available. Even we have followed some occupational therapy book also and found that lot of things have to do. And based on that, we have used lot of exercises. See the now the movement has come up, the chewing has come up. See the chewing has come up, and now he is enjoying actually. That is the part he is enjoying. See when there is a full-fledged biting, full-fledged chewing. It was not there, so it has been started functioning. And see here, slightly sensorium is better. Slightly sensorium is better. So see, and a lot of the neck resistance, because physiotherapists and occupational therapists, they have already they have worked fully. So lot of changes, at least for instructional aspects, understanding communication skills, some improvement I have got. And definitely the feedback, this, he is saying that there are some changes, some improvement what he is saying in Bengali. Uh, he is saying that the capacity of intaking food has been improved a lot, and the drooling is being significantly reduced. Some comprehensional aspect is there. The child is now cooperating with some understanding some instructions, basic instructions at least. And sound is also there. Ah, e, u, those sounds are also there. So these are the feedback. Now he is saying that when you are asking the name calling and something, patient is giving the response, and the child is able to chew even some semi-solid and solid also. That was not there. There is a significant improvement what we have found, and also parents are found in particular in the home level. They are using all those things. If we provide very small bolus, the intake is very found and formed. So in discussion part, the oral motor learning principles and oromotor sensory kits, both means with the tools, the appropriate tools, which was not there earlier in my college days, but nowadays it is there. So it definitely provides effective interventions. And I can talk more on that after another 6 or 8 months when this particular new new therapeutic postulates development will be completed. That we'll found we are actually getting a lot of new aspects when I am doing it on a lot of new populations of communication disorder, especially in an apraxic group, and found a lot of effective intervention area when we are using motor learning principles, using schema theory as well as schema theory, using some aspects of sports physiotherapy aspects, few principles of muscles through sensory integrations book from occupational therapy, using these specific Make in India tool, and getting the effective interventions. But it is now it's challenging, but it is there. So we have to document vividly, because I cannot tell at that particular point that how it is improving what are the different aspects of improvements, whether it is a bottom up or it is a top down or it is both, or how it is actually changing the oromotor control aspects. Definitely there is a mild gain in language and attentions, but whether it is explicitly due to the activity on language and attention, or due to the top bottom up principles or top down principles, the cognitions are also changing with reference to oromotor learning principles. Means oromotor learning principle is not working only to develop oromotor skills, but it changes the brain capacity to understand language and attention. That is a challenge, and we have to comment on that. But in this particular case study, I cannot conclude because it is a case study only. There is no structured methodology to prove that because of that, there is a gain of language and attentions, because we have not vividly worked on language and attention. Only oromotor learning principles can change the cognition. That is a challenging aspect to comment. And individualized task-based therapy, if we do the customizations using the kits, there are a lot of the kits are there, and then some guidelines are there in the particular kits, whatever kits may be. That may be foreign kits, stock tools, maybe that Indian make in India kits, or there are a lot of make in India kits are coming up. So whatever you are using, they have some guideline. But what is my aspects that if we can customize the particular tools for understanding the particular patient's a problem, that it can explicitly uh, given some impetus that definitely it works. So in conclusions, oral motor sensory kits effective in managing severe oral motor deficits. Definitely in this particular case we have got standardization of these tools recommended for cerebral palsy cases. Combining sensory input with structured practice supports functional communication. That is very, very important, that whether the input, sensory input, only stimulations, maybe speech or maybe non-speech, it changes the cognitive aspects, especially with reference to language. That is an area to explore in the future. So what is the flow chart in my this particular presentation? So input, that assessment of drooling by using the drooling quotient, plan for administrations of oral motor stimulations to children with cerebral palsy having drooling. Then the main part is that implementations of oral motor stimulations. It includes 4 interventions done around the oral cavity for 20 minutes. 1, tapping on both sides of the cheek, applying pressures on both cheeks, stroking the cheeks, stretching the corner of the child's mouth. 1 sessions daily for 1 month. That is the dose, therapeutic dose, which we have followed here. But it is a customized dose. That is also another challenge to categorize dose, which we are planning to do in this particular study, which is going on. And what is the output? That it changes in drooling after oral motor stimulations. Definitely that changes is there, whatever level it may be. And the feedback is going on. So those outputs are providing the input again. So it channelizing the particular loop. So it is kind of loop driven procedures as fully documented by Schmidt in the schema theory. And it is given in the also in the source like Quasar and R 2008, that is there in the Google. So these are my references in this particular study. It is already published. So if we I can also show few things like probably Debosmita, you have my full article also, no? Full article. If you have full article, then you can, if anybody wants that, you can also share, because it is basically a just one shot of glimpses. It is not a very like high level structured study, because it is only a case documentation. This is a case study. Though case study is nowadays uh, providing a lot of information, customized information, and very it is required to develop a bigger set of research. But we are using some nowadays we are using some quasi experimental studies here, and one trial is going on, though it is a non-randomized control trial, not randomized, non-randomized control trial, but still we are using it for this the quasi experimental design. So getting a lot of aspects of development in challenging aspects like non-verbal oral apraxia to oral apraxia, and there are a lot of things we are getting. So until and unless we are finishing it off, I cannot now comment on, because the study is going on. But we are getting a lot of different things in this particular study. So this much I can say. So thank you, Devusmita, for providing me opportunity. Here probably my two authors, Saheli and Rumela Adhikary, see both are there. So
Both have joined, sir. Yes.
both have joined. So if Rumela or Saheli can can contribute in this particular discussions, if Devusmita permits. So
Yes, please, sir. Please. More the merrier.
because they have done the lot of work. It is not my own work, and even my area of interest is not directly into the child language, but as Devosmita has constantly inspiring me that you talk on child language. So whatever I have in my hola, so I have given you that particular part, though I am fully interested in the other neuroscience part of the tinnitus, vestibular, and voice, but not on in this particular area. But Rumela and Sahili both were both my student, and they have finished their post graduations and other things, so they can contribute. So Rumela, please, and then Sahili. You can just
So my question is, both of them can also answer. So when the child came in, what was the feeding status of the child? Like the texture as well as the swallowing, how much was being thrown out, how much, in what position was the child eating? What was the child eating?
yeah. So actually, whatever I have found there, the child was in only the state of semi-solid and
Hmm.
liquid, but with
Okay.
some uh, difficulties. Not
Okay.
everything is inside. Sometimes they are outside. So there are a lot of drooling issues are also, and also spitting, not there in the mouth. So holding into the mouth, that is a issues. So that we have found it in this particular case, and because of the child is not is having like this, so there is
Hmm.
slightly opening of the mouth. Always it is there.
Always. Hmm.
It is there. So there is a lot of tensions here also. These particular aspects, there is a lot of tension. When we are measuring that, the tension I have
Yes.
got it. So these are the area. So and then first you have to start mobilizing this area so that the
Hmm.
mouth closure will be there. Lip seal will be improved. The lip seal
Yes.
development was improved, and then we start working on other internal aspects like tongue mobilizations and other
Hmm.
aspects, and then gradually it has been changed.
And sir, okay. And sir, what is the status of the epilepsy? Like when you were working through the therapy, you were devising the plan. Uh, what was the status of the therapy, the medicine? What was the status of the medicines being administered to him?
Yeah,
And was there any recent MRI just to understand if there are any significant changes in the brain, just so that we have a understanding of the actual physiology behind any
actually
evidence?
the
Huh.
first evidence is this person is having severe birth asphyxia under ventilations, probably meconium
Okay.
inductions and
Huh.
eclampsia or pre-eclampsia. That is the aspect. Then MRI shows the what I have found, that it is periventricular leukomalacia, that is the white matter injury, the very gross
Okay.
white matter diffused brain injury and atrophy. There is a shrinkage that was there
Hmm.
because of the lack of oxygen. Number three, but though they are not, they have only one MRI report I have seen, and I have seen is a diffused white matter grossly damaged in the MRI plate, and it has been mentioned periventricular leukomalacia with the gross white matter damage and the cerebral atrophy. That is the diagnosis mentioned in the MRI. Number three, the seizure is what I have found it is a tonic-clonic type of seizure. What I have found in the particular, so there are a lot of other classifications as the Jacobsonian, Petit mal, Cranmer. These are not used, but I have not found all those structured epilepsy. But I have found tonic-clonic epilepsy, and now that time that occurrence was 3 to 4 times per day, and they are taking the sodium valproate and also some Levipil, Lobazam, then some barbiturates also, then a lot of medications, neurological medications for stabilizing those things, but still it is very huge.
So that means basically, sir, it's an active comorbidity even when we are providing, intervention services. Basically, it's an active comorbidity. Basically,
Yes.
Okay. Okay. No, sir, I just wanted to make an addition. I have also worked with children with cerebral palsy, and what I wanted to put together some of the evidences that you were talking about. That once the physio, the occupational therapist, and we start working, there is a dramatic difference in the sensorium, sir. Because of the input that we are giving, there is definitely some neuroplastic rewiring that is changing. So even if you're providing, oral motor input, if you're irrespective bottom up or top down approaches, there is a huge difference in the sensorium, in the processing of the world, or even the child paying attention to the fact that the mother is feeding. Like, earlier the feeding was going on because obviously the parents feel the child needs to eat something, the child, there was a lot of spillage. But after basic physio and our oromotor inputs, are definitely the sensorium does improve, especially in very severe kids where you cannot work only directly on language, because they won't even, they won't understand why you're pointing, or they should look at something for us to understand. So yes, it does work a lot for, these severe kids. So you have a question from Aruna Prabhu. In case of mild oral sensory issues with speech sound disorders, how could you use these tools to improve intelligibility?
There are a lot of major methods that already mentioned in the literature. One is the pure oromotor stimulations, because like using that V pen, we can use the V pen like in the pen grip, and there are two type of stimulation. One is strong stimulation, one is weak stimulation. What do you mean by strong and weak stimulation? When you are putting any uh, triggered stimulation tool with the vibrator, first you have to do the non-vibrating stimulus, not the vibration stimulus, and you have to start working on the mouth without any vibrations. After, because it isn't called weak stimulus, because that can integrate easily, then you start vibrations. When it is in the mouth, you do some work without vibration, you slowly start vibration and categorizing the vibrations. But the vibrations should not be more than the alpha wave, the strain, the frequency of the alpha wave in the brain. That's why the oral B, then other brushes which were used for dental things, we cannot use it for the oral stimulation, because all those vibrations, the frequencies of occurrences are more than the brain vibrations, brain frequencies. So that will be easily rejected. It has been already found in the literature as we have coming through. So that's why there is a need of specifically designed tool for oromotor stimulation for vibrational aspect. That is number one. Number two, weak and strong, which I have got, because if you in the physiotherapy, if you go, so first when there is an tractions and when there is a movement, muscle movement, we slowly start in the weak stimulus, then we start a different type of jerk and different type of mobility. That is a method. Same method we can use it in the mouth, because it is small muscles, so we cannot provide much more strength and much more jerk to that. Even we cannot use chiropractic type jerk like Mulligan jerk and other type of jerk. because if you provide jerk, there will be a lot of chances that the muscles can be damaged. Interiorly, the nerve can be damaged, nerve root can be damaged. So those chiropractic, osteopathic, other physiotherapeutic mode I have already studied and found that if you stimulate all those different type of jerk, like Mulligan jerk is one type of example, if you use that, there will be a chances of the trigger and stimulations, the more stimulations, and there will be a lot of dysfunctions with the nerve and muscle, the aponeurosis can be cut. So that is another aspect we have to keep in mind. So in case of mild things, if you just use alternatively weak strong stimulus with the V pen and having some like the other the tools like Hickey and other things, or that particular the TT things. So if you put that into the V pen and you start mobilizing the tongue, if you tongue is there in the hole, and then we can just change moving the tongue in the different rotation, like right to left, clockwise, anti-clockwise, back, push forward. There are a lot of methods are there, but slowly you have to do with the weak first and then start the vibrations. In that way, if you do, there will be there will be a changes. So what I have found, but there are a lot of pedagogies, lot of theories are there behind the oromotor stimulations. Lot of people have given different theory. Even nowadays, I am seeing there are one techniques are coming up, oral sensory stimulation and something. But I am also developing a strategy with my student in the master's dissertations part. So until and unless we are completing it, I cannot comment vividly that these are the key areas that we should work on that. So it will be a change. So that is a part. But definitely, if you work the different level of weak to strong, there will be a change. What I have found.
Okay, sir, that was super helpful. Sir, Kushali is asking, where can we read up more on the use of these oral speech kits, oral motor speech kits? Where can we read up on these?
That is a very good question, actually. I have researched, or I have searched lot of things, even also in chatbot, ChatGPT. I have seen, but all time ChatGPT is not giving good references. And so we have to further validate with Gemini and other things that either the validations of the particular ChatGPT references are correct or not. We have some 2-3 books on oromotor stimulations, PDF I have got, and I have written to one of the author of particularly like one Skimit and another one 2-3 author of physiotherapy, that how they are doing the oromotor learning in the not oromotor learning, motor learning principles in the different body other muscles like cuff muscles, the gastrocnemius, peroneus longus. There are a lot of the string muscles, hamstring muscles. How they are using it in the sports injury and sports physiotherapy. Based on that, I have got a lot of different strategies, and we cannot combine all those strategies for one patient, because then only oromotor stimulation will take 2 to 3 hours, and it is dangerous because of the muscles will get fatigued. So we should not provide therapy for at least 30 minutes at a stretch. Then we have to provide at least 2-3 hours gap. Then we can provide another 30 minutes. In that we have to go. Because I have got that, because if you stimulate more than 30 minutes at a stretch in the mouth, there'll be a lot of fatigable issues will be there. And that leads to some damage. The nerve ending or aponeurosis damage will be there. So that should not be, that traumatization should not be there, because it is an ethical considerations. So physiotherapists and occupational therapists, they are writing more on the physical, the big muscles, hamstring and other things for sports things. But same principles, if we work for a small durations for our oral muscles, changes will be there. So we have to improvise, or we have to take some things from them. We have to implement, we have to categorize or validated by some experts, use it for a different methodology we have to set, go for a strong randomized or non-randomized research, and then we have to see that what is actually going on.
Hello. Hello.
Go ahead, please.
Hello, ma'am. And hello, sir. Ma'am, thanks for the nice initiative of article discussions. And hello, sir.
Yeah.
Sir, what I want to ask you that I have a two cases. Okay. First, I'll introduce about my two cases. Both are
Hmm.
CP cases. One
Hmm.
is a minimal verbal and other is a verbal kid. First, I'm talking about the verbal kid. Sir and ma'am, in this case, what happened now? The child is speaking, okay, but only the alveolar palatal sounds are affected. In this way, like his range of motions are affected, like tongue motions. Okay, he cannot elevate his tongue and not the lateralize his tongue to the right and the left side. I taken the opinion from the ENT, so they said there is a no tongue tie. Okay, I taken the opinion of the neurologist also. They said you have to do the lot of practice of a range of motion. The child has a difficulty in a chewing also. He is eating a semi-solid food. Okay, but the chewing is affected. So, what is my question to related to this article? Like in this, over there is written that in a oral assessment, the tongue movement has a zero, I guess. Okay, but the
Hmm.
child is starting chewing. So, what
Hmm.
I want to ask you that is what is the frequency of therapy you taken so it improved in such a way? Because for the counseling per se, we need such a basis that yeah, we tell the caregiver or the parents that you need to take such a frequency of therapy, then you can see the improvement. Because for the chewing, I introduced through the nibbler. Okay, but child is taken matlab a small quantity of a food and it's not helpful in that way. So, can you both guide on this?
Very strong question it is, and very beautiful question actually. We should think about that. This called dose, therapeutic dose. What you are talking about. So, what I have in this particular case, we have done that whatever we have done it. So we have recorded it and we have given it to the parents for carryover exercises. So daily 30 minutes for 3 days a week and carryover for 3 times in a day. It is the basic 30 minutes slot in each time, and the both in the you have to give 2 hours minimum gap between the two sessions. So it may be 3 sessions in the home, 1 session in the institute, and maybe in this way. But there should be 3 to 4 sessions daily. It should be practiced, and to make it homogeneity, you have to provide whatever you are doing. The video clip should be there stepwise. Otherwise, patients may do wrong things, and patients should be learned under supervisions of you, so that whatever things you are doing, at least 30 to 40% of this particular skill has been learned by the parents. That is another one aspect. So that has been carried out in this one. That is number one. Number two, probably those cases may be one problems called asteriognosis. This is the one apraxic conditions called asteriognosis. So poor oral asteriognosia, it is another aspect. So you have to do, because maybe there is no tongue tie, no ankyloglossia, because ankyloglossia there is a grade. You can see it. This particular part is attached. So it is an ankyloglossia. Grade 1, grade 2, grade 3, based on surgery is required. But in this particular case, there is a tongue motion restrictions because of the some severe neuroplasticity disturbances. So what you have to do, you have to work on the asteriognosia aspects using different type of mobilizations tool. Mobilizations means if the child is not able to do the movement, like it is not opening up or it is not touching the alveolar ridge or the heart palate or something, or retroflexion is affected, or is the palatal sounds are affected, fricative affricates are affected. So what you have to do, you have to start first the mobilization at that level. So it is like the child can do up to this, not this, up to this. So from that level, you have to start mobilizations to right, to left, and to motions, circular motions, the clockwise, anti-clockwise, so that the range means from back to some dorsum, frenulum to the tip of the tongue. This particular the muscles coordinations may start developing. That is called plasticity. Then gradually you have to do the stretching to the up. So whatever things I am now talking, that is based on the things called passivity, learning through passive motions, passivity. So in the Winthrop Phelps, in the physiotherapy, he has given different aspects like passive, active assisted, and active. There are three aspects of learning. In between, you have to use rest whenever it is necessary. So start with passivity. So you are working on that. Gradually, you have to provide rest in between so that the muscles can get the original energy again back to the energy. So because lot of ATP synthesis are going on when you are doing passive exercises, then you have to use an active assisted, means you are now giving some comment and something. By that time child starts moving up and something, and you have to give the cue, and wherever is not there is a fail, you have to provide the touch, so that you are giving passive also and little bit active. Gradually active assisted can boost active motion. So passive, rest, active assisted for a longer duration and carry over, then the active. In that way, you can develop one particular set of motional learning. So this is very important. And if there is a problem in tongue elevation, means you should not start with using tongue elevation exercises more and more, because tongue elevation means there's a problem in the back sides of the tongue and some lateral portion of the tongue. So you have to stimulate all those muscular aspects for the plasticity, changes of plasticity. Then only you can start developing the upward skill. So those physiological things should be also clear in this particular area. But again, whatever I am telling you, that is based on different aspects of knowledge from different strategies, from different interdisciplinary things. So we have to again prove whether straightforward or whether it is using Winthrop Phelps or Bobath approaches in the all these aspects. We can use it directly or whatever, or we can use combination mode. So that is the aspects. So we have to think more on that. Yes, it is an area of interest, what you are talking about.
Yeah, sir. Thank you so much what you explained about it.
Talk to the, like sir said, make sure that the parents are trained. See, if you are doing the exercises, we know what we are looking for. It is a completely new skill for the parent. So, like what sir said, get video while you are doing it, shoot video clips with the parent, and then ask the parent to do it in front of you. So, for example, like if you don't know crocheting or knitting, looking at somebody, you are not going to learn it. Okay, so you feel that, oh, it is so simple. It could be even a yoga or exercise strategy. By looking, we don't learn, we feel it is simple. So, one, what you mentioned is get the parent to do exactly what you are doing. Like sir said, okay, you have 30 minutes, you work for 30 minutes, you rest for 2 hours, you make sure, get this also done with the parent. If a parent is not able to do this, what is the work time that you can train the parent for? Then maybe you do 15-minute duration for maybe 4, 5, or 6 times a day. So work this out with the parent, that you are that you want to, how you want to work, the method in which you want to work. And the most important part, like sir said, you may not be, you have to explain the parent what you said about counseling, Priyadarshini. You have to counsel the parent that if it is elevation, my ultimate goal is elevation. I cannot start with elevation. Okay. So even if I do a passive exercise, even if I'm doing passive, then I'm doing active with assistance, I cannot start with elevation. I have to do many other range of motion exercises to finally get to elevation. So along with that, definitely look at the sensorium of the child. What are the other motor skills of the child? And if the children you're working with are CP and they're actively attending physiotherapy or occupational therapy, speak to them also. Your oral motors should not be at a time when the child is tired. It should be at a time if the physiotherapist has worked on head and neck dissociation. Okay, so these muscles are free and you work on range of motion on a long-term basis, you will get much better and sustainable results. The child will be able to retain the motor patterns you're teaching. As against that, suppose the physiotherapist has worked on the hands or only the chest cage movement, you may not get, you may get good breath control, but you may not get good range of motion on the head and neck muscles. As against that, if they have worked on some dissociation and then you work on oromotor, you get fantastic results. So for that, you have to talk to the physio that in this session, what are you doing? What kind of homework has been given to the parent? But just be considerate that, see, the parent has to feed the child, bathe the child, clean the child. So both, the parent may not be able to do both at home altogether. So see, in CP cases, it is very difficult to move forward. But if you keep these in mind, you may get some results which is motivating for both you as well as the parent to sort of keep working.
Okay, ma'am. Thank you so much for such a nice input.
Welcome. Sir, we have one more question from Kushali. Sir, could you please share the book or PDFs for oral motor stimulation and exercises? Sir, any references that we can put it in the chat box, any names, so it will help?
I think the author, one is the Caruso. One author is there, Caruso. That book is there with me, and another 2-3 books also I have, but I don't have the name. I am not remembering those names because see, this area is because of Devosmita I am now speaking. Because again, it is the out of beyond my expertise area. My area of expertise fully on tinnitus because my all research, and I am doing also my postdoctoral research is on tinnitus only, and neuromodulations and tinnitus, the magnetic stimulations, brain stimulations I am doing. So I am if you talk on any case study on all those areas, it may be a good, but it is a pediatric aspect. So I have very less not interest, but I have a less exposure actually on that particular area. Whatever I have learned from books, videos, some different presentations, conference presentations I have learned. So books are there, but I will share with you. But point is that whatever there will be a scope of learning from any conference or any hands-on sessions, any workshops, because a lot of online, offline workshops, even Devosmita is doing a lot of work on the online platform. I am seeing a lot of work she is doing. So it is an excellent, Devosmita, what is you are doing those things because people will learn. So that learning is very, very important. So you have to also take care of all those things which are doing and available in our national level also, because there are a lot of experts, a lot of my seniors, my juniors, my colleagues, they are doing also that work. So you have to check some videos. Even some foreign videos are also there in the YouTube and other platforms. So you have to check what they are doing actually. And as well as some books, if I have the books, definitely I will share. But again, we cannot talk about sharing the books because there are some issues.
Copyright issues.
So that confidential legal issues, we cannot talk openly in the platform. So we will do it. And then another thing of learning these things are basically some research articles. So if you if you see some JSLHR, the speech language hearing research, ASHA articles, they are the last 4 or 5 or more than that, the volume, they have one and other oromotor aspects presentations, articles are there. So if we read all those new articles, even some neurology, some World Federation of Neuro Rehabilitation, WFNR, if we read then pediatric dysphagia, those particular articles on pediatric dysphagia, we will get a lot of things in this pediatric dysphagia, because pediatric dysphagia is a new domain of interest nowadays in deglutology.
Yes.
So that part also you can read out. So definitely I will help. Whatever I have a very limited resources, I will definitely help.
No, sir, thank you. And sir, Rumela and Saheli both also have put up names of authors and books in the chat box. We can definitely search. And Kushali, to answer you, and you know what sir is putting, both. I'm just joining the dots for you. Don't just read about the oral motor and the speech. Read about the basic schema, like sir was talking about earlier. You have to connect them to principles of both what is used in physiotherapy or occupational therapy to understand the basic neuroplasticity which is behind it. So, like sir was saying, it is not here, it is here. So if you want to work and make changes here, you need to understand a lot of other issues, other things which are going on beside it for one small range of motion to improve over here, you know. So not just about speech and speech motor, we have to read many other things also. That's how sir presented, right? So just a general input, but you have got a lot of resources in the chat box here. So thank you so much. Sir, I will just quickly share this with you. Sir, this is a very small token of appreciation for insightful, being so busy. You're a
Oh,
teacher
thank you very
and
much.
associated in a college. So
Thank
thank
you
you
very
so
much.
much for the time, for making the presentation and enlightening all of us. Um, I would also share a screen and just show the participants here one thing in particular. I'll just see if this screen is coming up. So this is Insightful Pediatric SLP. This is how the website looks like. This, including Sir's discussion here today, is going to be available in this section called Vlogs. If you can see, this is all free resources. Many people have written blogs, few people have written blogs. The rest are videos, the rest are case discussions, which are there. There are many till date. They are all free resources. You can watch them, you can read it. All the videos are here. And if you're interested, there are 8 paid courses also which are available, which attacks very niche skills. If you want to level up as a clinician, you have lifetime access once you pay, and you choose what do you want to watch, basically. So thank you everyone for making it on a Sunday morning, and thank you sir for enlightening us with so much more than just the article discussion. So thank you for your time. And
Thank you,
I-
Devasmita, for giving me opportunity. It is a new aspects, but I have learned, and it is a new area. What I have today, I have presented. Before that, I have not presented in this particular area. It is my first time presentations on child language. That is also with you, and you are doing a remarkable job in your clinical practice, in your academic job, and in this particular initiative, what you have done from your own side. It is very, very interesting because case study provides much more customized impetus or improvisations.
correct.
So if you understand a lot of things from case study, so that from the case study we can think for a bigger research. So if we have to
Yes.
establish a bigger research design, so we have to understand what is the what is the case, what is the actually
Yes.
improvisation is going on in the case. Based on that, we can think of for a bigger research or very structured or semi-structured research. So that is a very wonderful aspects what Devasmita is doing.
Thank
Um,
Thank
I
you, sir. And on this topic, sir, I'll get in touch with you. The what you finish after 8 months, sir, we are definitely very interested to know about that as well. So once that master dissertation is also done, sir, we will definitely talk about this and discuss this. Because like you say, sir, after a big research article also, it has to help us in through particular cases only, right?
true,
So,
true.
so yes, sir. So the discussion, the knowledge is very helpful, sir. So thank you so much, sir. We'll wind up.
Thank you all of you and who have listened me,
Joined.
and thank you, Namaskar. Thank you.
Okay. Bye bye, sir.
Bye, bye.
Bye bye.